All right, I'm going to go ahead and get started. I know folks are still entering, but since we only have an hour, and that's, of course, nowhere near the time that we might use to discuss the topic for today, we should just get rolling. So let me begin with an official welcome to this next or most recent in the series of epidemic ethics seminars. I want to send you all, first of all, thanks for coming and send you all wishes that you're faring as well as possible in, what continue to be difficult times for many, many of us. So in this gathering, this particular seminar of the Epidemic Ethics series, we're going to be focusing specifically on ethical questions and concerns surrounding the experiences of migrant communities in the context of the COVID-19 pandemic. I'm Lisa Eckenwiler. I'm based in Washington, D.C. in the United States. I'm professor of philosophy at George Mason University, which is located in Virginia on the other side of the Potomac and situated on the traditional lands of the Piscataway, Kanoy, and Doeg peoples. I'm joined, I'm thrilled to say, by colleagues who are based in Beirut, in Bologna, in Italy, and in Singapore, who bring rich and diverse expertise concerning migrants and refugees in different parts of the world, near conflict zones, in and around in the Middle East, in the Mediterranean region, Northern Europe, and also Southeast Asia. They also speak to different populations, including, for instance, people in refugee camps, pregnant women, mothers, children on the move, migrant laborers. Our subject matter, migrant communities, indeed encompasses a wide range of people and contexts, which of course makes generalizations really difficult. Migrant workers sometimes are residing legally, sometimes without documentation, employed in settings from construction to care labor, and dwelling most often in less than fully habitable and sometimes genuinely hostile conditions. We are thinking about asylum seekers in humanitarian settings, formal contexts of so-called aid, usually in remote, segregated, carceral out places, using the language of Michel Foucault, designed to, quote, park and guard, quoting an anthropologist, Michel Augier, who reside there only briefly, or, as is increasingly the case, over protracted periods of time, unable to repatriate or relocate in destination countries with tightening immigration regimes. We're also thinking about people in informal encampments, or even refugees in destination countries who are not always well integrated. Migrants and refugees live in many genres of precarity. Asylum seekers awaiting decisions with little access to services, migrant workers with rights to work but no other rights, functioning at the whims of employers with little oversight, foreign educated health and long-term care workers, the thing most dear to my heart, on the front lines of under-resourced and risky work, afraid to complain. As the global pandemic of COVID began to unfurl, it became clear quickly that the vulnerable would become still more vulnerable. And so it has been with the people we're concerned with in this seminar, wherever and however they are situated in the modern day apparatus of migration. They've faced heightened risk and scrutiny, diminished resources, increased isolation and segregation, forcible expulsion, and also live with a certain distrust that can deter them from seeking help even when they are eligible for it. And in turn, disproportionate illness and death. We might ask why this is the case. I would suggest a structural injustice analysis, and we can attribute this suffering to social norms and stereotypes, global economic structures that concentrate capital, exclusion from decision-making processes, and more. Given what we've seen, deepening inequities for migrants in the wake of COVID, what's warranted ethically to help prevent further erosion of ethics and health, and also thinking forward to prepare for a future where migration and threats to global public health are both to be expected. I'm thrilled, as I said, to be joined by three colleagues here who are going to be the panelists for today. So let me introduce them. I think in alphabetical order, but saving myself for the last. First, let me introduce you to Dr. Thalia Arawi, who is trained in philosophy and is founding director of the Salim El Hos Bioethics and Professionalism program at the American University of Beirut Faculty of Medicine and Medical Center, which holds the distinction of being the first and only regional bioethics and professionalism program in the Arab region, and also is a WHO collaborating center for ethics. Dr. Arawi is the first Arab member to be appointed on the board of the International Association of Bioethics. I'm delighted to say I get to work with her in that context. Has also been elected as a senior fellow at the GE2P2 Global Foundation. Perhaps she can explain to us what that is, because I don't know what it stands for, I'm sorry to say. Dr. Arawi has co-authored the first Arabic dictionary of bioethics terms with Dr. Ruhu Balbaki, and has just released her second book, just a book launch a couple of weeks ago, Toward a Post-Flexnerian Revolution, Graduating the Virtuous Physician. She's also senior editor of a recent special issue of the AMA Journal of Ethics dedicated to healthcare in conflict zones. That's hot off the press. Don't miss it. And finally, her research interests are quite broad in the areas of clinical ethics, humanitarian medicine ethics and refugees, bioethics in conflict zones, ethics in mental health, and medical education. Now, I hasten to add that with Dr. Arawi and with all of the speakers, I'm giving you a really abbreviated bio because everyone is so interesting and experienced. Next, we have Dr. Vanessa Groti, who is an associate professor of anthropology, a truly transdisciplinary team we have at the Department of Cultural Heritage of the University of Bologna on the Ravenna campus. She is a social and medical anthropologist and recently concluded an ERC-funded project entitled EU Border Care, which examined migration, maternity care, and reproductive health in European borderlands. Dr. Grotti is also the co-investigator on a collaborative project which studies migrant death, mourning, and memorialization in the Mediterranean and the Adriatic, entitled Ecologies of Remembrance, the moral afterlives of migrant human remains along the central Mediterranean route. She has been conducting long-term ethnographic fieldwork in northeastern Amazonia since 2002 and in the Mediterranean since 2015. She's published on medicine and colonialism, kinship and gender, personhood, animism and material culture, migration and borderlands, and history and memorialization. Dr. Jane Lim is a research fellow at the National University of Singapore Center for Biomedical Ethics, and currently a member of the Epidemic Ethics Project funded by the Wellcome Trust and the UK Department for International Development in collaboration with the WHO. Under the Epidemic Ethics Project, Dr. Lim's research focuses on developing appropriate resources to assist institutions, researchers, policymakers, and communities in addressing ethical issues within the context of global health emergencies. Her academic background is in infectious diseases epidemiology, with a focus on the behavioral aspects of cross-sector antibiotic resistance. Last, feeling a bit awkward introducing myself, but here goes. Yours truly is professor and recently, for better or worse, chair of the Department of Philosophy at George Mason University. I teach courses in bioethics and global health ethics. My research centers on vulnerability and structural health injustice, with particular interests in migration and humanitarian health ethics. Some of my current projects include a study of the ethical closure of humanitarian projects, another looking at structural barriers faced by refugees with disability. I'm the lead editor for a collection we just got a contract for, Forced Migration and Health Justice, that will eventually be coming out with Oxford, co-editor of a forthcoming book, Paradise or Purgatory, Refugee Accommodations in Europe and Australia, that will be out with Palgrave. And I'm also interested in this notion of ethical placemaking that I've been working to develop. And so I'm working on a book called Placemaking for Health Justice with Routledge, that will allegedly be out in a couple of years. I'm also vice president of the International Association of Bioethics. and a fellow at the Hastings Center. So I'll leave it at that. So again, truly transdisciplinary group with really diverse experience to help us tackle today's topic. Sorry for that violent metaphor, to help us address today's topic. So before I talk about the logistics for the day, let me just really reiterate my thanks to all of you for coming, to the organizers, and for the invitation to become acquainted with such really interesting new colleagues and to host this really important conversation that I hope will generate more friendships with all of the participants and future collaboration. So it's not just a one-off, folks, we hope today. So here's the plan. Each of our panelists, beginning with Dr. Arawi, will be offering her own introductory comments. Our hosts at the WHO have asked that we speak to 3 particular questions, and they are these. How can we safeguard the rights of migrant communities during public health emergencies? What measures may be justifiable to maintain both population health and individual health and human rights in settings of extreme vulnerability, such as refugee camps? Third, can public health emergencies justify the selective use of public health restrictions which disproportionately affect vulnerable communities, such as migrants and refugees? So the panelists will be addressing these in their remarks to a certain extent, but being the slightly contrary people who we are, especially we disruptive philosophers, in our conversation, we raised questions about some of the questions, the way they were framed, and maybe some of their background assumptions. So let me just begin with that. We worried a little bit about the suggestion that migrants and refugees are exceptions or aberrations. We wonder if in fact they're the norm. We wondered about how to interpret the language justify. To whom would we be justifying restrictions? Who would be informing decisions about those restrictions? We asked if there was a background assumption here about scarcity, and whether we should be troubling that assumption. Last, we asked about whether nationalism and borders receive enough scrutiny in our thinking about health governance, and health justice. So we understand that there are really practical, really pressing, concrete questions that policymakers and others are trying to address, but we feel it's really important to step back and ask questions about the questions as well. A few final notes. As I said, for those who joined in the first couple of minutes, please feel free to say hello using the chat function. If you have questions, we ask that you pose those using the Q&A function. And also please like the questions that you are especially interested in seeing discussed, because that helps prioritize them. Last thing, the seminar is being recorded and will be posted on the Epidemiological website in the coming days. I will try to remind you of that bit toward the end. So now, with that, I will be quiet and I will turn it over to Dr. Thalia Arawi.
Okay, thank you, Dr. Lisa. Much appreciated. Thank you for your humbling introduction and for having me as part of this event. I know we are limited in time, so I will try to limit my discussion by addressing two main things. I hope that's okay. See, there's a problem here. Okay, so the first thing I'd like to do is to talk about migrant workers. So let me begin by noting, and this is something you already alluded to, Lisa, that the mere fact that there's a distinction between workers and migrant workers is by itself morally questionable. We are workers, all of us, with the same rights, and we possess the same dignity. The COVID crisis not only exposed the structural inequities of the labor sector, but it even aggravated the gap between local and migrant workers, unfortunately. So the so-called migrant workers are the ones who are truly forgotten and live in, if I may say, crises within crises. While they are important members of our societies, and we all know they are often frontliners, they work in healthcare centers, delivery personnel, housekeeping, and what have you. These are all very important things that need to be done, and they do the work for us. They face racial injustice, I'm sorry to use that term, be it directly or indirectly. And COVID made matters a little bit more blatant. These people suffered social inequities, although I don't like to say these because we are one, like difficulty in obtaining healthcare coverage or compensation. Some were placed last on the list for taking the vaccines, etc. And often employers tend to choose to protect local workers to the detriment of foreign ones. During the pandemic, many were forced to repatriation without any prospect. And there is evidence, unfortunately, all over the world of xenophobia, which can be seen almost everywhere when it comes to migrant workers, refugees, asylum seekers, etc. They are treated as de trop, as we say in French, as an excess. They are treated as second-class human beings, as disposables, to say the least, living in a constant state of exception, as you also noted at the beginning. I think to address the question one way or another, it is high time for the world to open their eyes and recognize that we are all human beings, we are all the same. We need to open our eyes and face the fact that not doing so is racism under a novel colonial face. So this is a brief statement about workers, migrant workers. Now, the second concern is that about refugees, okay? Among others, of course. So I don't know if you're familiar or if the audience is familiar with Ghassan Kanafani, and who wrote a very interesting short novel called Men in the Sun. In Men in the Sun, Kanafani recounts the story of 3 refugees and their unsuccessful attempts to travel even stealthily from country to country. They were actually trying to go to Kuwait in search for a recovered life for them and their families. Now, their life in refugee camps clearly was harsh enough to push them to a very risky journey. When the smuggler they hide inside an empty water tank, actually, and succumb to unbearable heat while their smuggler is held up at the border. But when the smuggler discovers their bodies, the novel ends with a very interesting, poignant question. Why didn't you knock on the sides of the tank? Why didn't you say anything? Why? And I'll come back to that question shortly. So the term refugee has been for some decades abused and placed within a motionless classification, if I may say, as if there were a tacit pact among those in power that refugees are displaced people who will remain displaced, who must continue to rely on external help for subsistence, and who suffer the impact of COVID-19 and other pathologies of power for reasons mainly beyond their control. There seems to be an implicit agreement, even acquiescence, that refugees are people who cannot and should not live beyond what Giorgio Agamben calls bare life, under the mandate of a Foucauldian biopower, a power over life, the biopolitics that decides who gets to live and who gets to die, which controls entire populations, including children and the elderly. Now, children and the elderly is another topic that is very dear to me, but I won't embark on that. But suffices at this moment to highlight the unacceptability of looking at children being killed and maimed every day in camps as collateral damage. The word collateral damage here is disgraceful, and I do recommend a book by Dr. Nadira Shalhoub-Kevorkian where she speaks of unchilding, and that's what she calls it. So we have a moral obligation to address the question, to help refugees, displaced populations, asylum workers, who, as you said, Lisa, at the beginning, are afraid to complain. We have a moral obligation to help them to knock on the sides of the tank, alluded to earlier on. And when they cannot, we must knock on their behalf. They are equal human beings with equal rights, needs, and a rational plan of life. So refugee camps, by definition, must exist temporarily. When they become a land dwelling for the disqualified, the problem will never be solved. I recall Picasso, the painter, once saying, "Everything we can imagine is possible." What we need then is a leap of imagination to make things better. Imagination coupled with moral courage. Because normalizing refugee camps, to me at least, seems like a moral aberration. So you see, humans are exploring the secrets of the universe and life in outer space. They are working on artificial intelligence. We are speaking of the metaverse, of biohubs, and what have you. I'm sure human beings can do much more to remedy that state of deplorable and unacceptable out of placeness, to use the words of Edward Said. Not doing so is a discrimination and racism at its worst. And it seems to me that this xenophobia is a pandemic and no one is truly even trying to find a vaccine or a cure. Now, I don't want to take much more time, but allow me to end with Denise Da Silva's rhetorical question in her very interesting book, Law, Raciality, and Violence. She says, where is that place where what should not happen to nobody happens every day? Why is it that in so many places, found in every corner of the global space, so many human beings face that which no one deserves? So that's her question. I would argue that what makes possible a mode of existence that spreads beyond, actually that's her again, what makes possible a mode of existence that spreads beyond the judicial borders of any given state and the ethical borders of every nation. I think we need to stop paying lip service and denounce structural violence from afar with empty words, with empty commiserations, and particularly with what I would call morally vacuous condolences, when we just pay our condolences without really feeling what the other person is suffering. It is worth also to mention a poem, a part of a poem by Aimé Césaire, where he says, "For the work of man is only just the beginning, and it remains to conquer all the violence entrenched in the recesses of his passion. And no race holds a monopoly of beauty, of intelligence, of strength, and there's a place for all at the rendezvous of victory." Thank you.
Thank you so much, Dr. Arawi. Thank you for a really compelling set of comments. We really appreciate that to really kickstart things. Now let's go to Professor Vanessa Groti.
Thank you, Watina. I'm just so humbled by what Thalia just said, and thank you again so much as well, Lisa, for introducing me with your kind words. And I'm very honored to be on this panel, and I think it's just such an important topic. And I really hope that all of you participating want to also join us in the discussion with your questions and comments and insights from all the specific parts of the world that you're based in. So I just really love the way this discussion started because it really centered on some of the key concepts that I think are fundamental to try to understand the connection between migration and the COVID-19 pandemic. And fundamentally, we've heard structural violence, xenophobia, racism, and fundamentally the question of rights. And I would like to start by this idea of rights, by inviting you also to reflect on some of the key concepts that are often so politicized and so used vacuously to justify also specific means in an emergency, in a context of emergency. So first of all, let's just go back to the basics. So the rights. I want to talk about two rights: rights to mobility and right to health. So rights to mobility are at the core of anybody working on migration studies, because we have to acknowledge an existing structural inequity when it comes to mobility. There is such a thing as passport index. Depending on your citizenship and your nationality, you're going to be able to cross borders and to reside in host countries and transit countries on different means. And this is a fundamental human rights inequality. That means that not all of humanity is equal when it comes to traveling, to moving, for any means, for any reason. There is no need to really, and so turning away from this discourse of justification, really thinking of a right to mobility that should be intrinsic and equal to all human beings. So why is it so important? Because when we talk about migration and this idea of migrants, this is a term which is defined by the International Migration Organization, the IOM, as a sort of an umbrella term that doesn't really have any legal seating. So you can put into migrant lots of categories, and we've discussed categories such as migrant workers or asylum seekers and refugees, and they all fit on this idea of global mobility, people involved in the migration process, but they just encapsulate so many different forms of life stories, collective and personal and individual. And it's very important to always keep in mind the context when it comes to the legal context, entitlements that people have, wherever they are located, whether we're talking about international borders or internal borders. Internal borders, what we mean is forms of bureaucratic processes which complicate access to services that migrants may have in a host transit country. So when we think about migrants, of course, we're discussing here international migration in particular. And this is one of the key contributions that I want to make, really reflecting about what we could observe during the COVID pandemic from 2020 onwards at the borders. So when it comes to medicine at the border, but also treatment of human beings at borders. And within borders, I also include border infrastructure, so the migration business infrastructure. And that sort of means formal and informal forms of detention or camps that we can see. So extending into all these different kind of architectural forms that sort of burgeon out of borders. But borders are also laws, they're also practices and policies, and this is also fundamental. So borders exist on paper in the way people treat other people, so how humans treat other humans, but also in the infrastructure, how they then aggregate them. And this is when COVID-19 comes to be extremely complicated. But of course, it's really important to think that migrants, fundamentally mobility, migrants can also refer to any person in a context of mobility. And it's about the freedom that people have to choose to have a lifestyle which is not necessarily sedentary forever. So this is something that turns back to Michel Foucault and to this necessity, in a sense, that states have to want to account for all human beings and to sedentarize them and control them. So if we look at the case of Europe, where I've been working in particular in this context, we can really see this at play, because we have historic minorities who've always been nomadic or semi-nomadic and refused this push to sedentarize, and who now are placed very much have extremely low socioeconomic indicators and also lower health outcomes. We can think also of ethnic minorities, indigenous peoples who want to have a different kind of lifestyle, which is more mobile, but which is restricted often by nation states. And I'm thinking about Europe, but this is also something that we can find elsewhere. But here, when it comes to COVID-19, we've heard international migrants crossing borders, so people whose status legally is still in limbo, because asylum seekers, economic migrants, as we want to classify them, may not yet can be acknowledged when they reach their transit or even destination country. But also we have to think about diasporic communities, second generations, third generations, and the fact that the burden of migration or otherness, in a sense, is still something that's impacted them during the pandemic. And this is something to take into account, and I think there'll be more of a discussion on migrant workers. But I would really like to return to borders and look at what processes we observed from the very early months of 2020. As we all know, one of the first things that happened is that borders shut down and mobility was stopped. But what happens exactly precisely at borders, where people continued to attempt crossing because they were fleeing conflict or violence, we started realizing very soon that at national level, and this can be observed all over the world, knee-jerk reactions that push towards a hardening of borders and an arbitrary use of this sort of state of exception to contain people, so completely counterintuitive to sort of measures that should have been taken to protect people. Quite the opposite. So what we see, for example, we saw in the Mediterranean, we could witness the return of quarantine ships. So people who would be rescued at sea, being then detained into the ships, not being allowed to disembark and their application to be processed. So developing new forms of carceral containment, which really reminds us of the long history of quarantine that the Mediterranean produced since the 14th century. So really very much a return to these practices. And what we saw as well, so extending this into the further architecture and infrastructure of borders, is very much an extension of this push to close off, especially formal refugees camps, and extending bureaucratic processes, and in a sort of a punishing way. So exaggerating the amount of time that people were going to live in unsanitary, crowded conditions, and therefore exposing them, obviously, to illness. And this is something that we can observe across the world, but concretely, this is what we could observe during our ethnographic field research across various European international borderlands. So I will finish by returning to another fundamental right, which I think is really important, is the right to health. I truly believe that an answer to inequities in health is really to think of a system at national level which is universal and free at the point of delivery, and which doesn't make a distinction of deservedness between those that belong to the nation state and those that don't. That health should be enshrined as a constitutional right, which is for regardless of legal status. But what we can see, for example, when we look at EU member states, a lot of them are welfare states. That for some, especially, for example, if we look at Southern European member states like Spain, Greece, or Italy, they do have this constitutional right, and they do have systems of universal healthcare that are put in place, which in theory open care to anybody at point of delivery. But we can see that this, during the pandemic, this didn't mean that access was guaranteed equally. Inequities that we could observe in health access during the pandemic, that we could observe all over the world, were also very much observable in countries with universal healthcare. This is due to several factors, and I think that it's really important to study these factors and to understand. One is the lack of communication and information, and lack of education of anybody working in the border and migration regimes industry. They do not know, and so you can observe that on ground level. A lot of bureaucrats would become sort of migration officials, stopping access to services because there isn't even a lack of awareness when it comes to migration law and to rights to health. So I think fundamentally we should return to these ideas that there are structural inequities that we have to address, and that during the pandemic, of course, some specific parts, demographics and parts of the population at national and international level are going to be affected more, but it is high time that we start using the right words and concepts to really name what we are observing. This is not just random. Often there is no epidemiological justification. We're just observing just the strengthening of arbitrary states of emergency just for the sake of it, because a pandemic is kind of quite useful to do this. And this is historic. If we look at history of medicine, we can see that throughout time, previous pandemics have just enabled similar systems to be built into place. So I'll stop it at here. Thank you very much again for the invitation, and I'm looking forward to the discussion.
Terrific. Thank you so much, Professor Grotti. Oh, let's see. Okay, good. And so now for our final panelist, let's turn to Dr. Jane Lim.
Hi, everyone. And thanks, Lisa, for that kind introduction earlier. I'm incredibly honored and happy to be at this webinar together with Lisa, Thalia, Vanessa, and all of you on such an important and urgent topic. So I'll get started. Today, I'll be speaking about the ethical considerations through the lens of the migrant worker community in Singapore. So a slightly different perspective of the migrant worker community discussion that Thalia started earlier. More specifically, I'll be focusing on the low-wage migrant worker community who undertake precarious work. So while they are integrated into the country's labor force, they face other types of social and economic vulnerabilities. So it's just some quick context about the community before I continue. Singapore has currently over 1 million migrant workers, making up between 35 to 40% of the labor force. So these are largely low-wage workers from countries like Bangladesh, India, China, Myanmar, Thailand, and Philippines who hold highly restrictive work visas. And they often work in labor-intensive sectors such as domestic work, construction, manufacturing, shipbuilding, ship repair, etc. So despite their sort of integration into the labor sector, this community experiences structural inequalities as well as implicit and explicit forms of othering, or the us versus them phenomenon in other ways. Many of them were exacerbated during the COVID-19 pandemic, such as their precarity in their work arrangements, healthcare access pathways, their economic conditions, the experience differentiated pandemic policies, as well as media narratives and discourse surrounding the community. So in preliminary results of a media analysis we conducted of local mainstream media, we found that othering narratives occurred across many different contexts, such as the objectification of migrant workers as low-skilled labor, or in the context of delayed economic outputs, the racialization of migrant workers often, as well as the differential reporting of COVID-19 cases and the vaccination uptake rates in dormitories versus the wider community. So these were some of the examples of othering narratives that we found in local mainstream media. But inevitably, I think one of the most salient examples of vulnerabilities during this time was their epidemiological vulnerability, given the nature of the pandemic, which is what I'll be elaborating a little bit more on today. So currently in Singapore, most migrant workers live in structures called purpose-built dormitories, and these structures are situated away from the wider community. These dorms can house anywhere from 3,000 to 25,000 workers, and the facilities are designed for communal living. So there are shared kitchens, shared bathrooms, etc. But these dormitories are very often very densely populated. So you can have anywhere from 12 to 20 men in a room, which makes it extremely challenging to implement any sort of infection prevention and control measures. So even though Singapore managed quite early containment of the COVID-19 outbreak, these living arrangements subsequently led to massive outbreaks in migrant worker dormitories. So by May 2020, I think, migrant worker cases made up about 90% of all the COVID-19 cases in the country. And then this was consequently followed by a lockdown where workers were confined to their rooms despite the risk of increased transmission within their living arrangements. So it's important to note that these are definitely not issues unique to Singapore. The disproportionate exposure and impact of the pandemic on similarly set up migrant worker communities have been documented elsewhere in Southeast Asia, as well as the Middle East, for example. And while the community has experienced previous outbreaks of other infectious diseases, such as malaria, dengue, Zika prior to COVID-19, the pandemic finally compelled some major changes in the physical infrastructure of the migrant worker communities, an environment that is so crucial to the community's living and social and health resilience. So in September last year, new policies for improved standards were developed across government ministries and industry partners to include things like larger living spaces and better ventilation in shared spaces in newly built migrant worker dormitories. Similarly, as the pandemic highlighted the need for more rapid response to public health concerns in dorms, another larger scale policy that was recently implemented in November was the introduction of a new healthcare financing scheme for both employers and migrant workers that will hopefully serve to provide more affordable and accessible primary healthcare. On a smaller scale, as a result of the pandemic, there have been a number of ground-up initiatives implemented during the pandemic, ranging from addressing food security needs to advocacy to mental and emotional well-being. While these are all necessary, I think a larger question would be how we can start to formalize more of these initiatives, or how we can start to even include migrant workers in decision-making processes that can enable policy changes to build more resilience and empowerment and equity in the community. So as countries move toward COVID-19 endemicity and have slightly more capacity for interventional change, I think it's important that we think about how we start to go about creating more inclusive and sustainable policies that can enable us to be more proactive instead of reactive in safeguarding migrant workers' health in the face of future public health emergencies. So I'm gonna stop right there. Thank you very much.
Thank you so much, Dr. Lim, for rounding out the set of presentations that we have from the panelists, all of which were really compelling, even riveting, I would say. So thank you all so much for that. We have questions, of course, the three that our colleagues have asked us to address. So those are still sort of in the background, if you will, as things that might be the focus for the remaining time that we have for discussion, which is just about 20 minutes. I've also got just a couple questions in the Q&A, a couple, mostly comments, but only a couple of questions. So what I think I'd like to do is start quickly to see if panelists have questions for each other, and just give each of you a chance to ask one question of the others. And then let me probably just turn to the questions that are being raised by our attendees in the chat. So why don't we, let's see, Thalia, if you have questions for anyone, then Vanessa, if you have questions for panelists, Jane, you have questions, and then we'll take it to the other participants. Thalia.
Thank you very much. Thank you, Dr. Jane, Dr. Vanessa, and Dr. Lisa. Really, I'm really learning a lot and enjoying what I'm listening to. But I have one question that always lurks in my mind. We are all talking about refugees and migrant workers, displacement, rights to mobility, and what have you. And there are lots of laws out there. There are lots of regulations and decrees out there. And yet we keep on seeing these decrees and laws and regulations being challenged, disrespected. So my question is, what is the real relevance of such regulations beyond an intellectual exercise if those who breach such laws and regulations are not held accountable? So that's the main question that comes to mind. And thank you again.
So we have policies, we have international legal instruments. In other words, we have all of these declarations, right to health, and so on and so forth, that are brazenly violated at this point, right? So now what then? Do you want to direct that to anyone in particular?
Anyone, no one in particular, including you, Dr. Lisa.
Yeah, let me see if the panelists have things to say.
I'm happy to come in, but I would really love to. I think this is a fantastic question. Thank you so much. And I mean, I think we could go on for hours on this. And there's no single solution to answering it. But the quick answer is that when we look at what happened recently with the war in Ukraine, and Ukrainian refugees pouring into the European Union, for the first time, the European Union activated a directive which automatically made it extremely simple, streamlined in a sense, receiving, hosting, supporting materially, and in terms of access to health, the Ukrainians who were coming in. This directive had existed for 3 years. It was never activated, for example, for Syrian populations and for others. So what we need is, how do we know about this? And we've started hearing a lot of activists and academics very much stressing this point, and trying to hold accountable as much as possible those that decided that for some reason what was happening right now has been happening in the past few months is more deserving of a collective response than for previous crises. And I don't think there's a fundamental answer to this, but I really hope to learn from all of you. What I have found is that the profound resources of local support infrastructures. So activists are also researchers who try to develop their own initiatives, informing, researching, documenting, but also connecting to trying to join more academics to activism circle.
Jane, did you want to chime in a little bit? You can pass if you want, just.
Thank you. I'll try to contribute from the standpoint, I think, of workers in precarious situations. And part of what contributes to that arrangement and their vulnerabilities is really the diffusion of responsibilities across all the actors who are responsible for their health. And in this case, if we're talking about it. So I think, like Professor Vanessa said, there is no simple answer for this. I think it would include, putting in mechanisms at every single point to make sure to hold different parties accountable in this case.
I just want to give 2 sentences here and then see how fast time dissipates. It's so frustrating. So there's a really interesting philosopher, Fuyuki Kurosawa, who has this book, The Work of Global Justice. And what's interesting about this book is that Kurosawa makes an argument about at once the importance of kinds of like legal, juridical kinds of interventions. But then at the same time, he says, look, a lot of the work of, use the language you want, human rights, promoting justice, we want to think about like the labor. And he's really talking very often about the labor of civil society. So he talks about like AIDS activists and work on the quilt to try to, elicit compassion, in the hearts of people around the world who are sort of hostile, to people who've been living with HIV and AIDS, particularly if they're members of other minority communities. And then he talks about the work of solidarity movements. So I think that one of the interesting things is the role of civil society and kind of ordinary citizens in kind of stimulating the moral imagination by the kinds of labor, community-based work that they engage in to support a whole range of people, but including migrants. And that rather than the work, not to put ourselves out of business here, of making ethical argument, the work is to try to, just what Thalia said, support people's moral imaginations to think about the experience of others. So thinking about what that labor is, right? Like telling counter narratives in media, or the work of filmmakers like Ai Weiwei and his film Human Flow, or the work of photographers, right? That like help show people, looking like to help evoke compassion, rather than thinking, oh, look, these people are dirty. And, like, again, like the way that the media adds to the othering. So we've got the legal instruments, but that in itself isn't going to do the work of enriching people's moral imaginations. And so figuring out what that is, I think, is one of the answers to that, I would say. Let's do this. Vanessa and Jane, if you have questions, how could you ask them? And rather than asking them each other, let's just raise them. And then let me go to the questions that are in the Q&A, and then let's just open it up for discussion. So just raise it, and then we won't discuss it as panelists, but just ask the questions if you each have one, and then I'll go to the questions posed by our audience members. Fair enough?
Thank you. I don't have a question. I just want to hear everybody else.
Fair enough. Okay. How about you, Jane? Is there anything that you want to see discussed a little more?
I have no burning question right now, so I would
Okay.
say, yep.
All right. Fantastic. Well, then I won't read the comments, but I want to, say thank you to the people who offered them, but they just affirm much of what you all have said about marginalization, limited access to services, increased restrictions, more and more violence, hate crimes, those kinds of comments. So here's a question from Laurel Baldwin Raghavan. Apologies if I don't pronounce it exactly right. Thank you, Vanessa, for engaging the discourse of rights around migration and health. Could you please address the existing remedies, redress available to migrants when their rights are violated? So what resources do people have to turn to? So how do you see such mechanisms working? So I'll leave it at that, right? So when things are bleak, what resources do people have, if any? Like, where can they turn?
Thank you. Well, I think maybe I can ground it in very concrete research that we conducted on access to sexual reproductive health services during the pandemic, because we observed, in particular, we focused on Italy at the time. We observed that this is something that concerned all pregnant people in particular, for example, but widening the spectrum also any kind of sexual reproductive condition. But rights really affected the rights that were already available in law and provided by the state and by clinics, state clinics and private clinics, where we really observed that when it comes to sexual reproductive health, that they were reduced noticeably, preventing, for example, pregnant people from accessing termination that they were legally entitled to, simply by putting up barriers like small clinics being shut, services not being provided because all of a sudden they were not considered essential care. So immediately there was a sort of a response, again, connecting back to that, this idea of a civic sort of engagement or a civil society sort of trying to support. So new initiatives were rapidly developing, of course, first through online means, and then on the ground as soon as it was possible to move around, to try to reach out to those that were most affected. So in the case of the most vulnerable of all, women and pregnant people who were affected by these, they would be reached out by organizations that have been monitoring and following them all these months, but only via phone and internet when these people had access to the internet. So there was a strong awareness that there was such an inequity that it had to be responded. And this was, in a sense, heartening, but it's very scary. It was very scary to observe, and I think we do live in very scary times when it comes to sexual and reproductive health rights, because how quickly they are considered non-essential and they cut off, and there isn't a really concerted effort to extend it. So this is in particular in Southern European countries. We saw the opposite in Northern European countries of a deliberate attempt at sort of making more access, but there a stronger discrepancy between, again, national residents and then migrants, in particular those who didn't have legal status. So different forms of inequities that played out in different contexts. The response again is just really relying on local networks as much as possible, because large organizations do not have the local contacts and the capacity to really respond to the specificities of each situation when it comes to law and access to services.
Thank you for that. It raises so many important questions, not just about who is responsible, and I think we all have some pretty clear answers to that, but then if those people don't accept responsibilities, where do we turn? And how, if people who have responsibilities continue not to fulfill them or recognize them as such, then, what do we need to do to back to Jane's concern, to like rebuild systems and institutions that will, be more effective when it comes to, protecting and promoting the health of people in the world? And perhaps, reliance on the state, perhaps reliance on humanitarian organizations is not only unattainable, it's not necessarily clear it's desirable at this point, given that we see particularly the states being some of the worst perpetrators of rights violations against people. So, it raises questions, I think, about global governance of health, the role of borders, and so on. All right, a couple more questions. Let's see, we've got about 5 minutes left. So thank you for this important discussion. This is from Nadi Stadler. I hope, again, apologies for any pronunciation mistakes. Is there any further comment you'd have? It doesn't seem to be directed to anyone in particular. Any further comment you'd have as regards different categories of migrants, including migrant academics? If so, according to the evidence, are certain groups impacted by the COVID-19 pandemic differently? I think we would all agree the answer to that is yes, right? Like it varies according to privilege. Would you say? So I'll put that there. Here's one more from Namrata Sadarangani. Dr. Lim, how can we have more equity for healthcare access for migrant workers in Singapore? And I'll give you those two, and then there's one more it would be terrific if we could get to. So different categories of migrants, maybe just a quick comment upon how we respond to that from a policy or practice perspective. Yeah, I'll leave it at that. Any response to that? Thalia, you're muted. I don't know if you're trying to speak.
No, actually, I'm convincing Thalia not to speak.
It's one of those.
So really, to talk about policies, we go back to the initial question that I raised earlier on. But perhaps because we're running out of time, I think the best answer at this point would be for me to quote Albert Camus during his Nobel Peace Prize. When he got his Nobel Prize, he said, "Each generation doubtless feels called upon to reform the world. Mine knows that it will not reform it, but its task is perhaps even greater. It consists in preventing the world from destroying itself." So via policies, via institutions, states, governance, we have a very difficult task ahead. Perhaps even remolding new generations via new systems of education, awareness that we are all one and the same ephemeral, humane, finite beings. To share our fate, use the word of John Rawls. See, I told you I'm telling Thalia not to speak.
I'm doing the same thing to Lisa the whole time through, right? Like my final comment would be, what binds us to one another? Is it our constitutional, constitutions that we share, or is it our kind of fundamental ontological connections to one another, as human beings? Let me, because we are out of time, just read out two questions that we didn't have time to discuss, but they're, I think, ones that are probably the ones that we all need to go away and think about for the future. So from Owen Schaefer, what do panelists say to nationalists who say countries may reasonably prioritize the interests of citizens, right? So this is right at the heart of what we've been talking about. Like, what do you say, to your president or your prime minister who says, well, my obligations are to my citizens, and you would, perhaps want to resist that. There's another terrific question about right to health, the link to universal health across nations. So how do we ensure that, giving different economic situations around the world? Perhaps what's the role of the international community in helping make that right actually achievable? There's a terrific question from Leanne Pascoe here that asks us to speak about trust and the role of trust and trustworthiness when it comes to working with migrant communities. And then sadly, the one that came in at 8:59, I'm gonna leave. So really important questions about who has responsibilities, and over time, what are our fundamental obligations to each other? And if people are not fulfilling those responsibilities, then who's responsible for stepping in? Also, I think there was a lot in your comments about, if I may point to something I find really important, the role of place, people's living conditions, where they're going to access healthcare, what happens at borders, detention facilities, so on. All of this seems really central when we're thinking about migrants, because increasingly they're segregated and isolated, and place plays a really significant role in what happens to their health. So with that, let me just say thank you to everyone who's come. Remind you that this will be posted in the coming days on the Epidemic Ethics website. They asked me also to follow them on Twitter. And I hope I haven't forgotten anything else I was supposed to say. If not, please accept my apologies. Yeah, here you go in the chat. So there's the link for future seminars. So thanks to everyone for just a really terrific morning, afternoon, and evening. Jane is like gonna go call it a day at this point, since it's 9 p.m. for her. So I hope that you will all continue to be in touch, with us, with the organizers of the seminar series. And we look forward to crossing paths, if not in person, here virtually in the days ahead. So thanks for all of your work. And I'm sorry we didn't get more time together. All right, everyone, take good care, stay safe, try to do the right thing. Best of luck, everyone.